Welcome to Medicine in Our Backyard. It's good to see all of you tonight. This series is presented by the Newport Beach Public Library Foundation in partnership with UCI Health. And as Jerry said, my name is Adrienne Windsor. I'm a member of the board. We have with us tonight Mike Smith and his daughter Jen. Mike and Polly Smith. Mike is right back there. He may not want to stand up, but he can wave to you. Mike and Polly Smith have been the sponsors of this program since we started it. It's been more than a decade, and it's just been a real boon to the community that we have this opportunity to bring these amazing professional doctors and practitioners to speak to us about their specialties. They have such incredible credentials. So let me also thank tonight Kunga, our program director, and Jane, who's with UCI Health. They arrange this program for us. They bring the speakers to us, they coordinate it, and they are just so valuable to this community. And let me also acknowledge Jerry Capel. He is our CEO, and as he's talking about this lecture hall that's being built, he has headed up that capital campaign to raise half of the money for the lecture hall, which has been the task of the foundation. So it's quite a monumental thing. That building is going to cost $23 million, if you can believe that. So it's quite a gift to the community. All right, so we are a membership organization. How many of you are members? Quite a few, but quite a few of you are not. Now I want to entice you to become a member. On June 18th, we're going to have our summer solstice. This is a summer celebration, and it's especially to honor new members so that you can come and meet the board and meet other members of the foundation's community. We are having a really wonderful speaker, Michael Hitt. He's a LA Times business editorial writer, but he also is a Pulitzer Prize winner, and he's just come out with a new book, Golden State. It's the history of California. And he will be our keynote speaker at the summer solstice. So between now and the end of May, I want any of you who aren't members to become members. And Kunga will be happy to take your visa or your whatever and sign you up tonight. And if you don't sign up tonight, you can go online and do it. All right, so this will end with a Q&A session. So I hope you will hold your questions until the very end. And also I hope as you ask your questions that if you have a personal history that you refrain from telling us your whole story, because these are videotaped and they are on YouTube. And so if you can at least constrain your questions. And our speaker will be here afterwards, and you can come up and talk to him if you have a personal story you need to share. Remember to silence your phones. So now I'm happy to introduce our speaker tonight, Dr. Brian Hitt. He's a board-certified UCI Health behavioral neurologist who specializes in the diagnosis and management of Alzheimer's disease and other cognitive and memory disorders. He was just telling me a personal history. He first came to UCI as an intern when he was in high school, studying the brain and Alzheimer's. So he's had quite a remarkable voyage in gaining all of his professional expertise and then coming back to us. He earned his medical degree at Northwestern Feinberg School of Medicine in Chicago, Illinois. He completed both a neurology residency and a fellowship in cognitive and behavioral neurology at the University of Texas Southwestern Medical Center in Dallas. He holds a PhD in cell and molecular neuroscience from Northwestern University in Evanston, Illinois. And he completed a postdoctoral fellowship at the Center of Alzheimer's and Neurodegenerative Diseases at the University of Texas Southwestern Medical Center. And then UCI called him back, so he has come home. So please join me in welcoming him tonight, Dr. Brian Hitt.
There we go. Thank you very much. Thank you all for being here. So I'm Brian Hitt. I'm one of the neurologists at UC Irvine in the memory clinic. And so I diagnose and treat diseases of brain aging, which a lot of that is Alzheimer's disease. And that's what I spoke about mainly when I spoke here 2 years ago. But I find that one of the most common questions that I get, and the thing that a lot of people have a lot of curiosity about, and that I think there's kind of not enough of an understanding about, so what is the difference? How do we use the terms dementia versus Alzheimer's disease? When is dementia not Alzheimer's disease? And when it's not, what are the other things that can cause Alzheimer's disease? So I wanted to cover that tonight, and kind of highlight a few of the other conditions that can cause dementia. And also, I kind of just want to give an introduction to dementia. What do we mean by that term? How is it defined? And then highlight kind of a few of the non-Alzheimer's disease dementias, particularly vascular dementia, dementia with Lewy bodies, and then a category of dementias called the frontotemporal dementias, and then a few kind of miscellaneous ones. I want to end by talking about, in the clinic, how do we tell them apart? And then, why is that important? How do we manage them? What's our approach to treating these conditions? So, introduction to dementia. I'm going to define dementia, but I also want to distinguish it from a couple things that are not dementia, that are, can kind of sometimes seem like it. So dementia is, it's important to note that dementia is more of a symptom than it is a disease. I like to say that people come to me not to, get diagnosed with dementia, but they say, I have dementia, why do I have dementia? What's the cause of it? It's not a specific disease process. It's the word that we use to say that somebody needs help with their daily activities from a caregiver, and it's because of cognitive impairment, memory loss or some other trouble with thinking, and not from an injury or weakness or something like that. So one of the key features is that you have to have some a need for assistance from somebody else, and it has to be because of cognitive impairment. This is a cognitive impairment that's gradual in onset, is slow in progression, and is not in the context of an acute illness like an infection, a hospitalization, big swings in your blood sugar or blood pressure, and not in the context of a psychiatric crisis. The key to kind of the definition of dementia is a need for assistance with activities of daily living, which are broken into the basic activities of daily living and the instrumental activities of daily living. And so these instrumental activities of daily living are the more complicated things, the things that often you start having trouble with first. Like driving or arranging transportation for yourself, managing medications independently, managing finances, keeping your schedule independently, shopping on your own, and keeping your living space clean. And then kind of later on, people may start having difficulty with the basic things, feeding yourself, using the bathroom, bathing, dressing, grooming. So kind of any type of dementia from any cause progresses through a number of kind of predictable stages, and we actually define the stages not based on any kind of blood tests or imaging that we can do. It's all based on your independence with activities of daily living. There are a number of different staging systems. I like to use kind of this system where we kind of talk about 4 steps in the progression, all based on what somebody needs help with. So if you have some cognitive impairment that's definitely a change, definitely more than just kind of what's expected for your age, but it's not enough to impact your functional independence with these activities of daily living, That's how we define mild cognitive impairment, or MCI. When people start needing help with the more complicated things, the instrumental ADLs, but are still independent with all the basic things, that's mild dementia. When you start needing help with even the basic things, that's how we define moderate dementia. And severe dementia is when you need full assistance from a caregiver with all functions. I think it's really important to distinguish dementia from normal cognitive aging. And oftentimes the first question that we have to answer when someone comes to see me in clinic is, are we even seeing anything that is more than just what we expect for normal aging? Normal cognitive aging is a real thing. And it mainly involves a decline in your processing speed. Processing speed peaks somewhere around your 30s and declines from there. It's very gradual, very subtle. Some people notice it more than other people do. And in particular, people who have kind of a high cognitive baseline, have high expectations for themselves cognitively, have gotten used to being able to multitask a lot. That gets harder for all of us as we get older. And so those people generally, I tend to see them, kind of noticing their normal cognitive aging and being concerned about it. Kind of the sharp drop off and starting to, kind of affect activities of daily living is kind of what distinguishes dementia from that. So, kind of with processing speed being the main thing affected, really the thing that limits is the bandwidth of your attention. That kind of shrinks, meaning that you need to focus on one thing at a time and can't really divide your attention between things. So the things you might notice, you might forget what you went into a room to do. It might take longer to think of names or words. Harder to do two things at once, like have a conversation while driving or some other type of multitasking. If you're walking across the room to write something down and somebody says something to you across the room, what you were thinking of might just escape from your head. And you might rely more on written reminders. All of these things are 100% completely normal parts of cognitive aging and are not a sign of a progressive brain disease at all. The other thing I want to distinguish from dementia is delirium, and this is kind of the cognitive impairment and confusion that happens in the context of acute medical illness or a hospitalization. People can get very confused, disoriented, can say things that don't make sense, can see things that aren't there, can have delusions, can be hard to wake up or hard to kind of get to interact. Kind of most people over 65 in the hospital and almost all people over 65 in an ICU will have some degree of delirium. It's also very common with infections, especially and almost ubiquitous in urinary tract infections in people over 65. Totally expected. I point this out because this can be distressing and surprising to family members, and there can be a disconnect between why are the medical professionals in the hospital here not as concerned as we are? It's because this is kind of very common, very expected. This is something that if you kind of walk around the hospital, most people over 65 in the hospital are going to have delirium to some extent. Pain and pain medications can both contribute to that, so that's a delicate balancing act. Most people will have some delirium coming out of general anesthesia. We don't have medications to treat it. We don't use medications to treat it. In fact, we try to kind of simplify the medications, if anything, because a lot of medications can make it worse. So, kind of treating the underlying cause, the acute medical illness, is the main thing that we do. And the main goal is to return somebody to their familiar environment, their familiar surroundings, familiar routine. Reinforcing the sleep-wake cycle really helps to kind of clear it quicker. So, trying to minimize interruptions during the night and keep things dark and quiet, and then in the daytime, lights on, blinds open, lots of stimulation and activities and, kind of the familiar routine that they're used to. It can take a long time to clear, especially after a serious illness, and we don't expect people to go back to their 100% baseline before leaving the hospital. In fact, sometimes it takes a few weeks at home in that familiar environment before it clears. And this is not a sign of a progressive brain disease. This is something that can happen to anybody. So then there's the things that are dementia. And far and away, the most common cause of dementia is Alzheimer's disease. And if you add in all cases of Alzheimer's disease that kind of also have some features of vascular changes, also have some Lewy body pathology in them, it's about 75% of cases of dementia, are caused by Alzheimer's disease, which is a neurodegenerative disease. All neurodegenerative diseases involve sticky proteins building up in the brain. These are microscopic lesions, things that you can only see looking through a microscope at slices of stained brain tissue. And we do our best to kind of recognize patterns and make guesses as to what those protein changes in the brain are causing it. And in addition to Alzheimer's disease, which involves buildup of the beta amyloid and the tau proteins, there are other neurodegenerative diseases caused by buildup of other sticky proteins that I'm going to highlight a couple of today. But there's also conditions like vascular dementia, vascular cognitive impairment, which is the first one that I want to highlight today, because this is the second most common cause of dementia after Alzheimer's disease. It's actually part of a spectrum. Even short of dementia, we can see cognitive impairment, even mild cognitive impairment caused by vascular changes. So these are age-related changes to the smallest blood vessels in the brain, changes that happen to all of us, but in some people can cause symptoms like slowing of your processing speed, apathy, so kind of decreased motivated and spontaneous behavior, difficulty with attention, working memory, short-term memory. But in contrast to Alzheimer's disease, where the problem is difficulty forming the memory, with this it's more so kind of an inefficiency in calling up the memory, and with kind of cues and reminders, the memory really is there. And so that's how we kind of can use some examinations to see what we think, whether we think it might be this. And kind of what we see on the MRI is these kind of white fluffy cloud changes deep in the brain, the deep structures in the brain surrounding the fluid-filled spaces called the ventricles. That's in contrast to a stroke, which happens all at once from a clogged blood vessel. And stroke or multiple strokes can contribute and can be kind of part of the cause of vascular cognitive impairment and vascular dementia. But much more often than that, what we see is chronic ischemia. It's age-related changes to the small blood vessels that happen slowly and gradually over years, not all at once like a stroke. There are a number of risk factors. A lot of them are things that are not under your control. Genetic risk factors that you're born with. People that have had a stroke or a heart attack, that have heart disease, that have atrial fibrillation, an irregular heart rhythm, are at higher risk of vascular dementia. But there are a number of risk factors that kind of are modifiable. So working closely with your primary care doctor to manage high blood pressure, diabetes, high cholesterol, not smoking cigarettes, those are all things that can reduce risk of vascular dementia. This I want to linger on for a little bit, because I think of this whole discussion about vascular cognitive impairment, this is very practical. Since 2021, by law, any results of testing, including radiology reports, kind of get dumped in your lap in your MyChart account before you get a chance to sit down with a physician and interpret it. And you might kind of see some terms and Google them and, kind of maybe get worried. Important to note that a brain MRI of anybody over 50 is going to have some degree of chronic ischemia that is seen. And radiologists are always going to comment on it. They have to prove they're doing their job, so they're never going to let it slide. And, so you can see that, Google it, can bother you. They are going to comment on it. They're not necessarily going to say this is normal or a normal amount. The amount of chronic ischemia matters. A small amount is totally normal, is totally expected, and is not going to cause any problems cognitively or otherwise. So some of the things you'll see on a radiology report are microvascular ischemic disease, small vessel disease, white matter disease. We often have people in our office kind of crying, convinced that they have come down with this terrible disease called white matter disease. That's not a disease. It's just kind of commenting on these kind of little white fluffy specks and spots and patches that are part of brain aging to a certain extent. And if you do see that on the radiology report, it's important for you to sit down with a doctor who's looking at the actual images and not the radiology report to tell you if it's anything to worry about. The first neurodegenerative dementia that I want to highlight is dementia with Lewy bodies. This is the kind of second most common neurodegenerative cause of dementia after Alzheimer's disease. And it's actually more closely related to Parkinson's disease than it is to Alzheimer's disease. And it has 4 key diagnostic criteria. The first being fluctuating cognitive symptoms. So they're fluctuating, really good days, really bad days, and mostly affecting visuospatial processing and not memory like Alzheimer's disease does. That starts at about the same time as Parkinsonian movement changes. So kind of those two starting together are what kind of key us in to suspect dementia with Lewy bodies. Then most people, not all, but most will have visual hallucinations of people and animals. These are fully formed. These are in broad daylight during the daytime, not just at night in the dark. And people can have, and often have years before they develop these other symptoms, REM sleep behavior disorder, which is acting out your dreams. Not talking in your sleep, everybody does that, but actual purposeful movements, punching and kicking pirates that you're fighting with in your dreams, reaching for things, running in your sleep. And, when we use the term Parkinsonism, this is different than Parkinson's disease itself. This is the word that we use to refer to kind of a suite of symptoms, mostly affecting movements, that we do see in Parkinson's disease, but we can see in a number of other conditions. So the key features are a slow resting tremor that kind of most people associate strongly with Parkinson's disease, a general slowing down of movements and rigidity of the arms and legs and kind of the core muscles as well, postural instability, and the slow shuffling gait that you kind of associate with Parkinson's disease as well. There can be non-movement symptoms that are part of Parkinsonism as well. Decreased facial expressions and blinking, a softening of the voice, drooling, and what we can refer to as orthostatic hypotension, which is big drops in the blood pressure when you stand up, can lead to lightheadedness or even passing out, and constipation. We kind of say that in Parkinsonism, everything slows down, so movements and the digestion and thinking as well. So dementia with Lewy bodies was kind of ultimately determined to be the diagnosis of the actor Robin Williams, which was a surprise. During his life, his working diagnosis was actually a frontotemporal dementia because of the symptoms that he had. But they determined by autopsy that the ultimate diagnosis was dementia with Lewy bodies. And so what we see on an autopsy is the Lewy bodies themselves. So Lewy bodies refer to pathological lesions. These are these microscopic aggregations of proteins that you can only see through a microscope, stained brain tissue, and they're formed by a protein called alpha-synuclein. So these are kind of deposits in the brain cells of alpha-synuclein. It's one of 3 diseases that is caused by deposits of alpha-synuclein, one of the others being Parkinson's disease, rather. So, I kind of highlight that because Parkinson's disease also can involve dementia, usually much later into the disease after having motor symptoms of Parkinson's disease for a decade or more. But sometimes one of the challenges is saying, we've got Parkinsonism, we've got cognitive impairment. Is this Parkinson disease dementia, or is this dementia with Lewy bodies? There's also a third alpha-synucleinopathy called multiple systems atrophy, a very rare one where kind of the main symptom is that orthostatic hypotension, a dysfunction of the autonomic nervous system. Median age of onset is 76, so this is very much a disease of aging like Alzheimer's disease, and age is the main risk factor similar to Alzheimer's disease. And it's a pretty fast progressing form of dementia. So the life expectancy is generally about 5 to 7 years after diagnosis, whereas it's more like 10 or 12 years for Alzheimer's disease. This, like Alzheimer's disease, is a sporadic disease, meaning it's not inherited, it's not passed on from parent to child as a gene mutation. It's caused by hundreds of different risk factors that kind of all go into the pot. The next one I want to highlight is actually kind of a grouping, a category of a number of different clinical syndromes. And these are the frontotemporal dementias. This was kind of the diagnosis of Bruce Willis. Very, very recently, he kind of made public that he was diagnosed with one of these conditions. These do not affect memory, and in fact, memory is usually spared and mostly affect personality, behavior, and usage of language. So these are not so much kind of diseases of older age. These are young onset dementias for the most part, with the average age of onset being about 56. And actually 13% of cases start even before age 50. They're difficult to recognize, and kind of not all physicians in the community are going to be on the lookout for them. So oftentimes people go years before receiving a diagnosis. These are thought of as fairly kind of quickly progressing conditions, especially considering they mostly start in the 50s and have a survival somewhere between 7 and 13 years on average, which is pretty short if you develop symptoms starting in your 50s. But there's a wide variety of kind of speed at which they progress based on which clinical syndrome we're talking about. Most of them are sporadic, meaning kind of a complex mix of different risk factors, but there's about 10% that are due to certain gene mutations and passed on from parent to child. There are a number of different clinical syndromes. This is not even an exhaustive list, and I don't want to get too far into the details. Each of these is its own rabbit hole that I have, entire hour-long lectures for the residents on. But I do want to highlight the top 3, which are kind of the classic, most common variants of frontotemporal dementia. So the behavioral variant of frontotemporal dementia is the most common, far and away. And it's, early on, mostly involves a loss of motivation, apathy, withdrawing socially, and a loss of social graces, loss of empathy, not having as much inhibition, not having as much of a filter. So disinhibited behaviors, saying or doing things that are out of character for somebody, or maybe kind of socially unacceptable, rude, or hurtful, and not understanding why people are hurt by their actions or by them saying certain things. So this can cause a lot of marital discord, disrupted family relationships. Important to note that we're not making value judgments about these people. This isn't something they're choosing. This is kind of the way their brain is affected is altering their behavior in this way. Oftentimes one of the early things that kind of keys us into this is a job loss or a demotion. Some of the behavioral changes that can happen is repetitive, compulsive, or ritualistic behaviors. Food preferences can often change. People will want to eat the same things over and over again, eat more than before. And oftentimes people develop a significant sweet tooth, only want to eat sweet foods. Late on in pretty much any version of frontotemporal dementia, we often see movement symptoms as well. So arms and legs get rigid. There can be involuntary movements, loss of dexterity, loss of mobility. The second, kind of the second and third variants that I want to talk about are both versions of primary progressive aphasia. So aphasia is a term that means difficulty speaking. And so these are primarily changes in your use of language. In the case of semantic variant, it's loss of what words mean, but also what objects are, how you interact with them, and facts, concepts, the types of things you learn in school. First thing that tends to be impaired is your ability to name things, name objects, remember what they're called and what they're for. And that starts for uncommon words, the things we don't see as often. And then that progresses to more common words and objects. It's important to note that, the way we differentiate these from each other is based mostly on the early symptoms. But that doesn't mean that that's what the only symptoms are going to be through the progression of the disease, which is unfortunately can kind of lead to some difficult conversations for people who have kind of seen their loved one mostly have some pretty manageable symptoms of kind of difficulty with naming and things like that early on. But oftentimes, these conditions are all kind of funneling into the same endpoint, and they all do eventually involve a global cognitive decline and impaired ADL independence, requiring help for even the basic things. And so as frontotemporal dementias can progress, even these primary progressive aphasias, they can come to involve some of the features of other frontotemporal dementias, including the behavior symptoms that are typical of behavioral variant frontotemporal dementia. The other primary progressive aphasia is the non-fluent agrammatic variant, and this is a difficulty with actually producing speech. It's actually, trouble with pronunciation, getting your mouth to make the words. It can, early on, lead to a loss of fluency, halting speech, making grammatical errors, using shorter and simpler sentences where you're kind of leaving out the grammar, but then that very quickly progresses to communicating with single words and then kind of being nonverbal. Usually, early on, comprehension is preserved, and it's just a difficulty in kind of producing the language. There can be stuttering, there can be mispronunciations, and because it mainly involves kind of loss of tissue on the left side of your brain, which controls the right side of your body, and the left side of the brain is where most of the language areas are. You can have some subtle right-sided motor difficulties as well, which is kind of one of the things that can clue us into to this particular variant. This is a kind of a crazy-looking slide, but I just want to highlight here that just like frontotemporal dementias are kind of a complex umbrella of lots of different clinical variants, lots of different clinical syndromes. They can be caused by a number of different types of misfolded proteins and lesions from those proteins, including the tau protein, which is also involved in Alzheimer's disease, TDP43, which is also the cause of ALS, and another protein called fused in sarcoma, which causes some rare forms of frontotemporal dementia. And there's another kind of crazy busy slide, but the key concept here is that there's not a one-to-one matchup of these types of pathology to the clinical syndrome. So we can't tell, based on what someone is presenting with how their life is affected, what is kind of the underlying pathology. There can be a lot of crossover, including Alzheimer's disease can actually be the underlying pathology. And that doesn't mean these are kind of Alzheimer's disease, meaning late in onset, affecting short-term memory. It means they look just like one of these frontotemporal dementia variants. But when you look at the brain tissue at autopsy, it's the beta amyloid and the tau, just like in Alzheimer's disease, that was causing the frontotemporal dementia. So this is a complicated set of diseases. I want to highlight just a few other miscellaneous things, and I think the kind of most interesting one to point out that I've been kind of diagnosing more often recently is something called late. This has a long name. It's better to just call it late. It's called limbic predominant age-related TDP-43 encephalopathy, so caused by that same TDP-43 protein from frontotemporal dementia and ALS. And this just became a new official pathological diagnosis in 2019, so we're just kind of starting to recognize it. This is not such a bad news diagnosis, because this is very late in onset, usually after age 80, progresses very slowly past that point. Usually only affects short-term memory and to a fairly mild extent. So it kind of looks like the early stages of Alzheimer's disease, but a very, very mild and benign version of it. It's caused by these little TDP-43 aggregates in the brain tissue and mostly causes kind of a shrinking of the hippocampus, but doesn't affect kind of the rest of the brain the way Alzheimer's disease does typically. Another potential cause of dementia is something called normal pressure hydrocephalus, and this is basically the fluid-filled spaces of the brain called the ventricles blowing up like a water balloon and kind of pushing the brain tissue up into the skull and causing difficulties that way. This happens so slowly and gradually that the brain can just kind of adapt to it, which is why the pressure stays normal. So if we measure kind of the pressure of the spinal fluid, it's not increased in these cases. And what we see clinically is this affects people's walking in a way that's kind of particularly referred to as magnetic gait, so like people's feet are stuck to the floor with magnets. Cognitive impairment, mostly kind of a memory loss and a decline in kind of spontaneous or motivated behavior, so it can look like apathy. And urinary incontinence, and usually a type of urinary incontinence where it happens before people have an urgency, have a feeling that they need to go. And when we think we're seeing this and, kind of all our diagnostic tests, the MRI is looking like it, we actually get help from our colleagues in neurosurgery because the treatment for this is a surgical one. So this is placement of a VP shunt, a ventriculoperitoneal shunt, which is kind of a conduit, a tube connecting the ventricles in the brain to a space in your abdomen to help that fluid drain. And in some people, can dramatically improve their gait. Another one that I want to mention real briefly, you likely will not see this, in your life. This is a very, very rare condition, but kind of an interesting pathological entity is prion diseases, which are caused by a protein called prion protein. It's in all our brains, but in 1 in a million people, it will learn how to misfold in a sticky way and propagate very quickly throughout the brain in a way that causes the brain tissue to start looking spongy like this. There are a number of animal prion diseases that are well known, like mad cow disease that happens in cows. Kind of in the 90s and early 2000s had a big breakout in the United Kingdom. The most common human prion disease is Creutzfeldt-Jakob disease. Very, very rare. But the key thing about it is very rapidly progressive. This is hard to mistake for some other condition because nothing else can really cause this kind of rapid progression. This is labeled here in months, and that's the survival time for these various types of CJD, Creutzfeldt-Jakob disease. Survival time's typically about 6 to 12 months from the onset of the first symptoms. Mostly affects people around 60 years old, but there's a wide range there. Almost all are sporadic, just happens by roll of the dice. They're extremely rare inherited cases, vanishingly rare human-to-human transmissions through things like medical procedures like growth hormone preparations from cadaver pituitary. And these have we have measures that have shrunk these down to essentially zero likelihood. And there, was a time where there were some animal to human transmissions, and that was called variant CJD. It was from kind of eating contaminated meat from cows with mad cow disease. I always want to mention these reversible causes, and I think maybe 10 or 20 years ago we would focus more on kind of the vitamin deficiencies and infections, certain of which can cause cognitive impairment, even to the point of causing dementia. These are completely treatable, completely reversible. Those are thankfully very, very uncommon now because we're very good at kind of catching these, preventing them before they cause cognitive impairment or dementia. But what I do see quite frequently is people coming in with cognitive impairment, even to the point of affecting their ADL independence, that is really secondary to one of these reversible conditions, either sleep disorders, mood disorders, anxiety disorders, or chronic pain syndromes, which all have kind of a similar effect on the cognition, mostly affect your attention, ability to kind of control and shift your attention. And so people will come in saying, my family tells me I act like I have ADHD. Do I have ADHD? No, you haven't late in life developed a pediatric condition of the child or adolescent brain that causes you to not pay attention in school. It's likely caused by one of these reversible causes, like a sleep disorder, mood disorder, anxiety disorder. So how do we tell these causes of dementia apart in the clinic? To tell you the truth, sitting down with the patient and their family members and hearing the stories of how it has affected their life, what they've noticed and what the time course has been, that's 90%. That tells us, the answer most of the time. In addition to doing that, we do a full neuro exam, including a thorough cognitive exam. But oftentimes, to kind of corroborate what we're thinking based on those two things, we get additional testing, like neuropsychological testing, structural imaging with an MRI, sometimes higher order imaging with PET scans or other scans. And in some cases, we need to use what's called biomarkers, which is tests of proteins in the CSF, the blood, or now we have a skin biopsy to help with some things. So far and away, the extra tests that I can order that is most helpful in distinguishing causes of dementia from one another is neuropsychological testing. So, I can only test memory and, very briefly in the kind of office visits that I have. But with neuropsych testing, one of our neuropsychologists, PhD neuropsychologists, sits down for 3 or 4 hours of memory testing where they can test a number of different, what we call domains. They can test memory for verbal information, visual information, but they mix that in with things that rely more on your executive function, attention, visuospatial skills, language abilities, processing speed. And, they kind of work that all together to see really what is the pattern? What kinds of things do you have difficulty with? Does this look more like Alzheimer's disease, more like one of these other neurodegenerative causes, or does it look more like normal cognitive aging or an inattention that might be a mood disorder, an anxiety disorder, sleep apnea that would be completely treatable? This is extremely helpful. And that in combination with looking at the MRI, kind of will usually get us to being pretty confident of the diagnosis. And this is kind of a collection of MRI images that I keep around to kind of teach medical students patterns to look for as far as the atrophy or the volume loss pattern, what parts of the brain are getting smaller over time. We can also get metabolic imaging with an FDG PET scan to look for not atrophy patterns, but patterns in what parts of the brain are quieting down, being less active, using less energy. And those can kind of mirror, the atrophy patterns that we see that vary between these causes of dementia. And if we're suspecting a Parkinsonism, like Parkinson's disease or dementia with Lewy bodies, there's a certain part of the brain that tends to lose dopaminergic cells, and we have a special test of cells that use dopamine called the DAT scan, and we can see that kind of loss of that population of cells in Parkinsonisms. if we are really trying to answer the question, is this Alzheimer's disease or is this something else, we can use specific Alzheimer's disease biomarkers, which there's more and more of these days. Far and away, still the most reliable and accurate one is getting a lumbar puncture to look at the spinal fluid. There are 2 protein changes that happen between those. We can usually have pretty good confidence in answering that yes or no question. We also have an amyloid PET scan, which is kind of a special imaging for the beta amyloid protein that builds up in the brain. Very, very sensitive, but has a high rate of false positives. Not a good screening exam. And then you'll hear about these new blood tests that, are okay in certain circumstances, but I want to emphasize that one, certainly not a good screening exam. So as far as these kind of Alzheimer's disease biomarkers, the thing I want to emphasize is these are not good screening exams, meaning in somebody without the memory loss pattern that looks like Alzheimer's disease, a clinical syndrome that looks like Alzheimer's disease, these are worse than useless. They give us negative information. And so, should I go get those to find out if I have Alzheimer's disease? You should not. They do not tell you if you have or will get Alzheimer's disease. They only help if you have a clinical syndrome that we're trying to determine, is this Alzheimer's disease or something else? We would very much love to have that test that tells us who is going to get Alzheimer's disease. That in some ways would put us light years ahead of where we are in terms of what we can do clinically. We're just not there yet. Now, secondary to that DAT scan, we now have a tool called an alpha-synuclein skin biopsy. So alpha-synuclein that causes Parkinson's disease, Lewy body dementia, multiple systems atrophy. Those alpha-synuclein deposits that build up in the brain are also seen in the peripheral nerves of the skin. And so this is something very helpful in answering, are we seeing one of those 3 things or something else? So that's an interesting part of the workup that we have. So I want to finish with, what do we do about these conditions? And I always like to focus on 3 things when someone comes to see me with any cause of dementia. So caregiver support, managing risk factors, and what we can do to help with managing the symptoms. So caregiver support, I always want to know who is taking care of the patient and do they have the help that they need to provide for all the patient's needs. Are they burnt out? Do they need additional help? Do we need to enlist a home care provider to help out with some of those activities of daily living? Or would it be more appropriate, to look into a residential care facility like assisted living or memory care facilities? Risk factors. So, all the research that's been done, we still don't have really good prescriptions that we can write that slow down the progression, but we know a lot about risk factors that do impact the rate of progression. So cardiovascular risk factors. We talked about how important that is in vascular cognitive impairment, but it turns out vascular risk factors have something to do with essentially all of the causes of dementia that I talked about today. So managing those the best you can slow down the progression as well. But far and away, the things that we have the most evidence for slowing down the progression of any cause of cognitive impairment or dementia is physical activity level, social activity level, sleep quality, meaning how much deep sleep are you getting, and strategies to manage stress and anxiety. Those time and time again are the things that pop out as having the largest effect size on the rate of progression. So, then I always think about what can we do to help in managing the symptoms. And there's kind of medications that we use to manage the cognitive symptoms, meaning memory and other thinking symptoms. They don't have a dramatic effect, but in clinical trials, we see that groups of people taking them do a little better for a little longer than groups of people not taking them. And so that's our go-tos are acetylcholinesterase inhibitors like donepezil, and then the second medication that we often add for cognition is memantine. And that combination is our maximum therapy for the cognitive symptoms. In addition to those, we often need to manage associated symptoms like depression, anxiety, agitation, sometimes psychosis, like hallucinations and delusions. And a common symptom of dementia is day-night confusion, getting up and wandering at night, wanting to sleep all daytime. And, we can help, with managing and regulating that as well. And then some of these conditions also involve movement symptoms like Parkinsonism, and we do have medications that we use for that. We enlist the help of therapists quite a bit. So we send people to physical therapists for gait and balance training, occupational therapists to help with visuospatial impairments and help with performing activities of daily living. And then for people with aphasias or certain other kinds of cognitive impairment, our speech therapists can do what we call cognitive rehab, using exercises to kind of strengthen some of those cognitive skills, make them last longer. What we would very much like to have is not just symptomatic treatments that can kind of have a very brief effect in masking the symptoms, but we would like something that is disease modifying and actually affects the trajectory of the disease, slows it down, gives you more years where people have just mild symptoms, or slows it down to the point where people don't develop, moderate or severe dementia at all. And we're getting there with Alzheimer's disease. In the last 2 years, we have the first 2 disease-modifying therapies that have been approved by the FDA. They're not great. They are not for everybody. They have a lot of risks. They're fairly burdensome. These are not pills that you take. They're intravenous infusions of monoclonal antibodies that you have to go regularly to an infusion center and get. You have to get regular MRIs because they can cause bleeding or swelling in the brain. But in the clinical trials, they showed, and this is kind of a figure from the clinical trial of donanemab, the second one to get approved. Over the 18-month clinical trials, people getting these infusions progressed more slowly than people not getting the therapies. So we're getting there. This is the first step in a new way to treat Alzheimer's disease. And it marks a kind of new era of the way we treat Alzheimer's disease. We're now in the disease-modifying treatment era of Alzheimer's disease treatment, whereas for years we've been in the symptomatic treatment only. That's all we could do, and before that we could diagnose it but not treat it. We hope that this disease-modifying era is short-lived and we quickly transition to the preventing Alzheimer's disease. And so that's going to require 2 things. These disease-modifying treatments will have to get more effective, safer, cheaper. But the big thing is we will need to develop better ways to determine earlier on who is developing those very, very early brain changes so that we can start them early enough to really have a dramatic impact on the trajectory. Important to note, this is where we're at for Alzheimer's disease. For these other neurodegenerative dementias like Lewy body dementia, frontotemporal dementias, we're years behind that. We have some catching up to do. We really need to kind of build out the solid basic science understanding of how those proteins work and affect the brain. They've been a lot trickier than the beta amyloid protein that underlies Alzheimer's disease. So, still a lot of research at the laboratory level needed in the frontotemporal dementias. And I'll just end on my thank you slide here, with the information about a study that I'm an investigator on called the Beacon study. And this is looking at a group of people who's 60 and older without memory loss, trying to identify the earliest changes. How can we identify those earliest changes and get us closer to having those tests that are really going to make a dramatic difference? And so there's some information about that, the contact information. If you think you might be a good participant for this, we'd love for you to reach out. These are important scientific questions that we can only answer because people generously donate their time to help us out with it. They can't be done in a laboratory. If you feel like you would be a good participant for that, reach out to the email that's listed on the slide here. And I put up the phone number to schedule appointments with UCI Neurology if you have a loved one that you'd like to be seen in our memory clinic. So thank you very much for your attention. Hopefully I left some time for questions.
Thank you very much. So, is this on? Okay. Pardon? We'll be going around getting your questions.
Thank you. I'm a special ed teacher. I want to know what and if there is a correlation that you've seen in the lab between autism and a lot of this neuro stuff.
That's a fantastic question. That's something that I think we definitely are behind the 8 ball in understanding. So we talk a lot about normal cognitive aging. We have we feel like we have a good sense of, what that looks like. But in people with learning disabilities and people with autism spectrum disorder, and people with childhood ADHD, we don't necessarily have a clear picture of what normal brain aging looks like in those individuals. What challenges, kind of might come along as the processing speed of the brain, decreases. Some of those compensatory strategies that people use, people with learning disabilities that, they are able to get by with, may become more difficult to use as their processing speed decreases. So that is an area of research. We don't, speaking kind of anecdotally from my experience in the clinic, I have a number of patients that I've seen with a diagnosis of autism or a childhood learning disability like attention deficit hyperactivity disorder. And they do seem to have more challenges than the average person does, as their brain ages.
Thank you. Hi. Thank you for tonight, by the way. It was very well done, and I've learned a lot. Can somebody who has had a massive brain infection in the frontal temporal lobe area manifest years, like certainly after brain surgery in that area, and then years later manifest like a frontal temporal dementia individual, just from an infection in that area?
The short answer is yes, but I'll kind of divide that, in 2 branches there. So if there's significant damage to the tissue, as the brain ages, as kind of scar tissue can evolve, as time goes by, the symptoms that somebody has, the kind of lingering symptoms, can look very much like frontotemporal dementia. There can be kind of a lot of those behavior and personality changes and executive function, decision-making difficulties that overlap with frontotemporal dementia, just as the late effects of the damage caused by the infection. But any serious infection or inflammatory process in the brain also accelerates the processes that are kind of at work for any neurodegenerative condition. So it's also an independent risk factor specifically for Alzheimer's disease, because that's the real common one. And so, it's hard to put a number on it, but we definitely do see that head injuries, inflammatory processes like what we call encephalitis, an autoimmune encephalitis or an infectious encephalitis can put people at risk, at slightly increased risk of developing Alzheimer's disease or other neurodegenerative diseases.
Thank you.
Thanks.
Yeah, thank you. You showed a number of MRIs on your slides, and I was just wondering if there's anything in particular you look for in those MRIs that, or maybe you showed it tonight or didn't point it out, but I'm just curious if there's a few signs you look for right away or if there's a giveaway.
What I'm mostly looking for, in the clinic, when we're trying to answer the question, is this more than normal cognitive aging? Is this something else? is volume loss, and, you know, kind of where are we seeing that volume loss? So since all, you know, common things being common, the most common pattern that we see is the one that goes with Alzheimer's disease. And kind of the way we see that most is in what we call the coronal views, which is like when we're looking at you face to face, taking slices going back, the cross section of a structure called the hippocampus. First changes that will happen is it will flatten out and there'll be a pocket of fluid that develops above it. And it'll kind of, the normal architecture of it. So hippocampus is the Latin word for seahorse. You can think of the round body of the seahorse, round head of the seahorse, stacked on top of that kind of big round, you know, kind of two round structures stacked on top of each other. They usually completely take up the fluid-filled space that they sit within. But with the early changes of Alzheimer's disease, those layers kind of peel away from each other, becomes a thin snake that kind of sits on the floor of the ventricle, and you see the pocket of fluid. So we're mainly looking for that, but then also space opening up between the brain and the skull, widening of the valleys on the outside part of the brain. And if we're really seeing way more of that, way more of the kind of space between the brain and the skull, that cortical atrophy, and not so much the hippocampal volume loss, then we think about some other neurodegenerative process like a frontotemporal dementia, which is very much a cortical dementia. So those, and, you know, kind of a lot of the MRI images that I put up on that, you know, MRI imaging slide, those are different atrophy patterns that are characteristic of the different variants of frontotemporal dementia. But something that I didn't have time to get to today is there are 3 different atypical variants of Alzheimer's disease that can sometimes mimic frontotemporal dementias because they are very cortical predominant. And that tends to be a lot more common in people who develop Alzheimer's disease earlier, before the age of 75. People who develop it in their 50s or 60s are more likely to have one of those atypical variants. So that slide was mainly kind of the atrophy patterns of the different variants of frontotemporal dementia and the variants of atypical Alzheimer's disease that I train our residents to watch out for, so that, you know, we're not just looking for typical Alzheimer's disease, because those other things are in the mix.
I have a two-parter.
Uh-huh.
The first part is, are you seeing the usage of more nasal insulin as a treatment?
No.
No, okay. I have a neighbor who's swearing by it right now, but okay. No, okay, that's interesting. All right, then secondary, and if you have anything to elaborate on that, I welcome that too.
It's, you know, one of 130 different things that are in some form of clinical trial. It's not particularly late along that process and not particularly likely to be one of those things that shows a benefit, and one of the rare things that kind of becomes part of our evidence-based practice.
Got it. Okay, thank you. And then
But
the second part.
you
go
know,
ahead.
I'll try not to get too far along that rabbit hole, but just kind of along those lines, you'll see a lot of people. You know, if you're looking at social media, and kind of if you're kind of going to clinics that are not part of an academic medical center, a lot of people kind of like to skip some steps, especially entrepreneurial types, and they will not wait for kind of showing that this shows, you know, benefit beyond risk, as long as they can charge you for it.
Very good, thank you. The second thing was just to clarify the question about autism, and to say, I think what you were saying is you definitely see decline among those patients, but not necessarily that you're seeing more patients who have autism having Alzheimer's.
Exactly. So we can see a decline beyond what we would normally associate with normal cognitive aging, people struggling more as they get older, even without the neurodegenerative changes of Alzheimer's disease or something like it. So it's basically a way in which normal cognitive aging can cause, you know, challenges that do impact quality of life, and that we sometimes do need to treat symptomatically, even outside the context of one of these diagnoses. You know, being kind of a smaller subgroup, it's really hard to get a sense of numerically whether they have any kind of higher increased risk, you know, of these neurodegenerative conditions. So far, it doesn't look like it is, at least not, you know, to a large effect size.
Hello. If someone has been diagnosed with hearing loss, can you explain why it's important from a brain standpoint, why they wear their hearing aids?
100%. You've hit on one of my favorite topics that comes up in clinic a lot. So there's so few things that are modifiable that can, legitimately reduce your risk of developing a dementia, or can slow down the progression of it if it is happening. And fixing hearing loss and fixing vision loss, is one of those that's kind of being added to kind of the classic big four of, physical activity, social activity, sleep, stress. And consistency of hearing aids, there's two things about it. First of all, putting them on in the morning, even if you aren't expecting to have a big important conversation, is going to mean you pick up more and your brain is getting more input. So your memory is only as good as the information it's getting from your senses. And so that's real important, but also tolerability of the hearing aid is way better the more consistently you wear it. Sometimes early on people are bothered by the background noises that are picked up by the hearing aid, but you have to wear them consistently for your brain to know to filter out the background noise. Otherwise, it's going to sound too loud. So people often wear them too infrequently for that to go away, and they cite as the reason for that they're bothered by the background noise. But that's the way to make them go away, is to wear them consistently for a good amount of time. Then, it'll be a lot more tolerable.
I have a question.
Uh-huh.
If dementia ran in your family, what tests do you recommend for early detection?
I don't.
Okay, none?
We don't have that yet.
Okay. One other question on your, for the PET scans on your clinical trial. Aren't PET scans very high with ultraviolet, what am I trying to say, radiation? It's bad for you.
Ionizing radiation, yeah. So the PET scans that we do, and for the full, the full participation in the Beacon trial, there's 2 PET scans in the first year, and then we repeat the whole set of tests 2 years later. So a total of 4 PET scans. It's a small amount of ionizing radiation, so it's mainly because it uses a CT scan to get a map of your brain, which uses X-rays. There's also a small amount of radiation exposure from the actual radioactive tracer that we use. But when you add up the total from all 4 PET scans with the CT exposure and the radioactive tracer, adds up to about the same exposure you get just walking around on the surface of the Earth over about 10 years. So it's kind of on the order of what you get exposed to as part of your routine medical care.
They just came out with on the news about CT scans and how bad they are for you. You really shouldn't ever have CT scans.
I don't know if I would say you should never have CT scans, but they do involve exposure to ionizing radiation. So, lots and lots of them over your lifetime can slightly increase your overall cancer risk lifelong.
So is it true if you're losing your sense of smell that you have a higher chance of Alzheimer's?
It is. There are other things that can cause anosmia, or a loss of smell, that can happen on its own. But anosmia has been found to, at least in some people, be one of the very earliest symptoms of neurodegenerative disease, particularly Parkinson's disease and Alzheimer's disease. So it doesn't mean that you are developing or will develop one of those conditions, but it in some people can be one of the early signs, one of the early symptoms of it.
And the other thing is the practice of trying to memorize things can actually improve your memory.
I would say, I would amend that a little bit. If you're doing that as an exercise, just, as a sacrifice because you think it's, you need to do it to make your memory better, it's probably not going to have the same effect as finding something that you do for enjoyment's sake, that you really like doing, that has kind of one of 3 features. That is something that's physical in nature, that's something you do with other people, or especially something with some novelty, learning new information, learning new skills. Those are the 3 components that all the activities that show really good effect sizes in the well-done studies that, that we have in common. There's no one activity that is, the best one to do for everybody. But anything with one of those three factors usually will show, a pretty good protection of cognition. And so and the enjoyment is the key. So something that you will do for its own sake, that you'll be consistent with, that keeps your brain engaged. So definitely staying active does make a difference, but there's no one-size-fits-all solution.
Okay. There are 4 things to keep our brain sharp, exercise, diet, social connection, and sleep. One USC professor said to him, social connection is 1,000%, important. Another neurologist would say exercise. I want to know what is your number 1 recommendation among the 4, or I know they're all important, but some say this is number 1, this was number 1. Thank you.
Can't really give my opinion. I'll just rank them based on the strength of the evidence, and it's very clear the top one is physical activity. We've known it for 30 years. Every study that's ever been done just solidifies that more and more. Level of physical activity, and it's not just in humans, in animal models. If we give mice that get Alzheimer's disease running wheels, it progresses more slowly. So there's something about regular exercise, regular physical activity that slows down the aging of the brain, that slows down the neurodegenerative process. The effect size is large. Nothing else really comes close. Social connectedness is kind of a close second, I'd say, of kind of all the lifestyle factors, to tell you the truth. And people don't want this to be the answer. People don't like hearing it. But diet is probably the lowest on the, it has a very, very small effect size. It's way more important for your heart health. Choose your diet based on what's healthy for your heart, and you're already doing what's important for your brain. And just while I'm on that tip, restrictive diets are not recommended at all for anybody over 65, and there are none of them that are a benefit for cognition or reducing dementia risk. So don't let social media wellness influencers convince you otherwise.
Any more questions?
One more?
Oh,
Have you seen any correlation in your studies with an increase in diagnosing dementia with people that have had the COVID shots?
So no, the connection that we see with COVID, in my clinic, mostly in the 6 to 12 months after a real serious COVID infection, there can be some some increased confusion, some difficulty with attention, some trouble finding words, things like that. The good news is when we follow those people over time, it tends to improve over a short period of time. As far as, any kind of vaccine or, something that can rile up your immune system, it's been followed. Haven't seen a correlation, with that in brain aging in any studies that have been done.
So what is the effect of the recent governmental cuts to this program for Alzheimer's?
So, a lot of my colleagues are, very nervous and kind of playing it day by day, playing it by ear. I don't know anybody who has had any funding that they were counting on and kind of needed for, a big important study that was already planned, lose that or have it not come through, need to cancel big studies. So far in Beacon, we've been okay, but a lot of people with, kind of up and coming trainees, graduate students, postdocs trying to launch their career are, really nervous of, kind of whether the jobs and the funding are going to be available. I think things are changing rapidly. And so, we kind of trying not to be too histrionic about it and give it some time to settle out. But I do have a lot of colleagues in my department, in the neurology department, are primarily research and are primarily supported by NIH grants, and so they are very nervous about whether they're going to be able to keep doing the work that they've been doing.
We'll have one more question back here.
What about these supplements like Neuriva and all these other supplements that claim to, work wonders?
So no dietary supplement has been shown to benefit cognition or to reduce risk of getting dementia. Kind of the general guidelines that I give of supplements. So really the value of any dietary supplement is in avoiding a dietary deficiency in something. So certainly if people have a vitamin B12 deficiency or, some other B vitamin deficiencies, there can be neurological symptoms. And B12 deficiency is one of the ones that is very, very, kind of very closely associated with cognitive impairment in particular. So we test for it, and if people are low on that, we do supplement it. Most people in the United States could benefit from a little supplementation of vitamin D3. They're a little on the low side, so supplementing vitamin D3, vitamin B12 if you're on the low side of it. Things like fish oil supplements or other omega-3 fatty acid containing supplements, can't do harm. They're not going to break the bank. They're cheap. They're good for your heart. So no reason not to take those kind. The other one is curcumin, which is in turmeric supplements. Probably has some benefits for heart health and joint health, maybe for brain health as well. It's also not harmful and is cheap, so no reason not to. But most other things, and the ones that I would particularly avoid staying away from, is any proprietary blend of dietary supplements where they don't tell you necessarily, what's in them. Important to note that the dietary supplement industry in the United States is completely unregulated, essentially. So there's nobody doing quality control or safety control on the products. And so, there's kind of no way to guarantee their safety. And the other thing is any of the expensive ones. So, if they're charging you, $50, $60, $70 a bottle, there's nothing in there that's going to be, worth that. In particular, Prevagen, I think, is one that kind of sticks in our craw in particular because, there were 15 years ago, there was some, weak preliminary evidence that maybe this jellyfish protein that they isolated and, started producing as Prevagen may have some benefit. All the really good quality scientific studies got done and showed definitively it has zero effect, and the company has continued to market it otherwise and has lost a couple lawsuits for false advertising. But apparently I've been told they still have commercials during Jeopardy and things like that. It's a little devious, but yeah, not recommended. There's no evidence supporting those those supplements.
Thank you very much,
Thank
Dr.
you.
Hitt.
Thanks so much for your attention.
I think you've given those of us who walk into a room and forget why we went there some confidence that we're just aging. Remember, this will be on YouTube and on our website, and our next meeting will be on melanoma, and it will be held in the community room at the Civic Center. So hope to see you there.